All right, hello everybody. Thank you so much for being on our webinar today regarding community engagement at health centers, best practices for outreach, advocacy, and organizing with patients experiencing homeless. We're really excited. We've got a really good group of speakers today that are going to share some of their practices and some of the things that they've found to be successful when they think about engaging their patients who are experiencing homelessness in advocacy and how they've been successful at doing so. So just to get started off really quickly, my name is Alex Harris. I work at the National Association of Community Health Centers in the Grassroots Advocacy Department. And I want to give you guys a couple of tools, really quickly, housekeeping tools for this webinar. First of all, if you are not connected to audio for whatever reason, hopefully you are seeing this slide, and this will show you sort of where you can find audio information for the webinar. There it is again. And this is what it looks like when you open it up, and this is the way that you can join using a phone, or you can use your computer audio as well, whichever you prefer. And then I want to make sure you guys see this slide because this is the way that we're going to take questions, and we really, really, really want to get all of your questions and your feedback and comments too, of course. Please, it should be at the lower right hand of your screen is a chat box. Please submit all your questions to this chat box. Unfortunately, we're not able to unmute all of the lines because it causes a lot of background noise, but we do want your questions, and we want to make this as interactive as possible online. So just use that chat box, and you can send your question either to all participants so everybody can see it, or you can send it just to the panelists so that we see your question and we can make sure to take it. So whichever you prefer, but please don't be shy, and feel free to send your questions to us at any point during this webinar. And if we don't get to it throughout the course of the presentation, we'll definitely get to it at the end because we've saved some time for Q&A. So we want to make sure to get to all those. So without further ado, I'm of course working with my colleagues at the National Healthcare for the Homeless Council on this webinar, and I'm really excited that they're able to join me today and to give a little bit of an overview of the work that they do and make sure that you're in the loop about sort of their advocacy work and their role as the National Council. So I'm going to pass it over to Matt Warfield, who is going to kick off the presentation with a little bit about the Council.
Great, thanks so much, Alex. So my name is Matt Warfield. I'm the Health Policy Organizer with the National Healthcare for the Homeless Council. I'm going to start off by telling you a little bit about healthcare for the homeless in the Council and then pass it off to my colleague, Catherine. So homelessness is a significant barrier to good health. On average, homeless persons die 30 years sooner than their house counterparts. The constant stress of housing instability exacerbates health conditions that may otherwise be both preventable and easily treatable. Without housing and proper treatment, simple cuts become infected, routine colds develop into pneumonia, and manageable chronic disease such as asthma, hypertension, diabetes, and HIV become disabling, life-threatening, and costly conditions. As this figure shows, patients of health centers who are homeless have worse health conditions than non-homeless patients in every category. Numerous studies have shown that homelessness causes poor health causes homelessness, and the experience of homelessness makes it more difficult to engage in healthcare. Considering the complex needs of homeless persons, healthcare for the homeless approaches patient care through compassionate and persistent engagement, an emphasis on harm reduction and low barrier access to services, an understanding of the complex needs of vulnerable people and the intersection between homelessness and poor health, a whole person approach to care that includes medical, behavioral, and social services, a trusting and respectful relationship, and delivering comprehensive services through multidisciplinary teams. Healthcare for the homeless is a special population health center within the larger community health center movement. Healthcare for the homeless projects predominantly serve persons experiencing homelessness, and compared to other health centers, patients are more likely to be adult-aged, male, persons of color, and have higher rates of poverty and lack insurance. Healthcare for the homeless programs meet all the requirements of other health centers with the additional requirement to provide substance abuse services. HCH services can be provided in freestanding clinics serving only homeless patients within a traditional health center, at a homeless shelter or other type of social service site or public health department, on a mobile van, or literally on the streets. There are currently 268 Healthcare for the Homeless grantees, one in every state, with more than 2,500 service sites. In 2014, Healthcare for the Homeless programs provided care to more than 850,000 patients. The National Healthcare for the Homeless Council is a network of more than 10,000 doctors, nurses, social workers, patients, and advocates who share the mission to eliminate homelessness. We collaborate with government agencies and private institutions in order to solve complex problems associated with homelessness. Additionally, we provide support to public health centers and healthcare for the homeless programs in all 50 states. With a staff of 23, we engage in research, training, technical assistance, and advocacy to work towards meeting our mission of eliminating homelessness by ensuring comprehensive health care and secure housing for everyone. We believe that housing and health care are human rights that no one should be denied. I will now turn it over to Catherine to talk about ways our members and consumers engage with the Council.
Thank you, Matthew. My name is Catherine Kavanaugh. I am the consumer advocate with the National Healthcare for the Homeless Council. And I think as Matt mentioned, we have a number of organizational and individual members throughout the country who engage in our work, and there are numerous ways that engagement occurs. We are very based in the idea that every voice should be heard and respected at the table, so we have a number of ways that you can see of where we engage our members through different committee works on our governing membership in different membership groups, which help lead our focus and our work. I think important ways that we would like to talk about engaging consumers specifically is in every single one of these ways to engage that you see on your screen, consumers are engaged in each of those aspects. So we have consumers as a part of our governing membership, on our board of directors, and each of our membership groups, and they're often presenters at our conferences and trainings. We very much value the experience and the knowledge that they bring to the work, and we like to make sure that they are fully engaged in everything that we do, as it helps us better understand the needs of the population and help us craft meaningful solutions that can really address the problem. It also helps us maintain our focus on the populations we serve and ensure that we are providing best for the needs of the community. And furthermore, for the individuals, that's a lot of the benefit for us as an organization and for the work that we do. For the individuals who are engaged, it also gives space for the traditionally marginalized voices not only to be heard, but also listened and respected too. And when we're talking about clinical care and for individuals to be stably housed, it's important for them to feel that sense of self-esteem and self-worth, and the engagement of being not only heard but listened to and respected as an important voice at the table is important for them as human beings. So it's important for us to engage that in all of the work that we do. One very specific way that we engage consumers is the National Consumer Advisory Board. So this is one of our individual membership committees, which is made specifically of H-stage clients who have experienced homelessness. These individuals engage in a number of projects, including national surveys, events promotion, and are currently working specifically around areas of peer support and storytelling. But I think something that's important for NCAB is that it's not only a place for us to be inclusive of the voice of consumers, but it's really about creating space for the consumers to be guiding and deciding their work for themselves and leading the movement in the way that they are comfortable with. We don't want to be just solely engaging our consumers. We want to be really developing our consumers as leaders and having their space to really define the decisions that we are making. An important when we're talking about consumers and advocacy, these again are all the ways that the Council engages in advocacy. And once again, we feel that it is important for consumers to be engaged in all of these aspects. So we have consumers who are engaged in our policy committee who advocate with us to legislators, giving their personal testimony about their experiences on the ground so that they are better able to really humanize these issues that legislators can sometimes often see as numbers and figures, and really bring the on-the-ground experience and the human cost of some of the policy decisions that people make. So there are a number of ways that we engage consumers in advocacy that we find are very important in terms of helping to really highlight their story and the on-the-ground experience, as well as continuing the leadership development work that we do with our consumers in order to build a larger coalition for a social justice movement that not only ensures health and housing is human rights, but also promotes the inclusion of the voice of those most affected. At this point, I will now turn it over to Jenny Metzler, who will be sharing about some personal experiences about how Albuquerque Healthcare for the Homeless engages their consumers in their advocacy work.
Thanks, Catherine, and hello, everyone. I'm really happy to be here this afternoon. I'm going to present a little bit about some things that maybe we do in Albuquerque. We're experimenting a little bit. They'll also have very much in common with everything that Matt and Catherine have presented about the National Healthcare for the Homeless umbrella and support and philosophy, and hopefully complement what Jeff Foreman will be saying a little bit later, and then I hope also provoke some really good questions and conversation toward the end. So I'm the Executive Director of Albuquerque Healthcare for the Homeless. We're in Albuquerque, beautiful Albuquerque, New Mexico. We have been in existence we're celebrating our 30th year, which is our good and bad news. We do really well and believe in it, but we're really continuously chagrined that we still have to do this work outside of the more mainstream system. All the more reason to be very righteous about our mission, our social justice mission, which is on the first screen. Our vision is to live in a world that is just and without homelessness. And our mission is three-pronged and three interrelated prongs that are about providing services, both to individuals and collectively as part of a network and system and safety net, and also to really step up and be a leader in implementing collective solutions to homelessness in our communities and nationally, and as well to uphold a commitment to diversity and equity, which we think really underlies everything that we do. And is really relevant for the conversation at hand today, I believe. I just want to say a couple things in terms of terms. I will probably, throughout the next few minutes, use the term consumer, member, participant, client, and maybe user, maybe some others, somewhat interchangeably. We talk about that a lot here. We haven't settled on a term. I think we probably opt most for consumer or client, particularly from those who are engaged as our stakeholder community. The other thing that I want to say is that I'm framing from our organization from the broadest vision, mission, and principles approach, because the way that we have approached community engagement and consumer involvement and leadership in our organization and community is to really integrate and ingrain everything organizationally and institutionally. So consumer engagement overall is through our organizational structure, including and starting with governance, and then all the way through, including our advocacy work. I also want to say, just from a health center perspective, that Albuquerque Healthcare for the Homeless is a standalone. We're a freestanding Healthcare for the Homeless project and grantee. We provide very, very comprehensive and integrated medical and dental, primary care, behavioral health, and social services. And we do very extensive outreach. We provide care in the field, not as a separate outreach team, but how we deliver services, as well at a central campus just north of downtown Albuquerque. So again, I think what's really underlying why we do consumer engagement, why we do community involvement and leadership in our organization, is because it's really the right thing to do. We can't possibly end homelessness and fulfill our vision. We can't possibly be good stewards of community resources and uphold our social contract without engaging them. So it's nothing about us without us. It's not that it's always an easy thing to do when we're within an increasingly bureaucratic and very compliant health center structure, but it's very important to do. So we approach this understanding that anything we do will affect someone's life, and it better be the right thing, it better be informed, and they better be involved in making decisions at all levels of the organization, from their own care across to governing the organization, across to strategic alliances in the community and our strategic priorities. We also believe that really dispossessed and disenfranchised people can and should participate in governance and in advocacy and being a voice together effectively. So we consider our organization both of consumers and also made up of really good allies. So the way we do that, again, one of the primary ways we do it that I think may or may not be unique to Albuquerque, but it's something that we've really put a lot of our energy into, is to focus through the board structure and to have a very, very engaged, informed, and inclusive board. We know we make better decisions. We know that we'll leverage more resources and minds, and we know that we'll provide much better care. And that leads to the advocacy part of our mission to change the world, that indeed we fully intend to do that. I think that how that reflects through our advocacy agenda and all of our advocacy and policy work is that because we have consumers included as elected board members, that they're helping to set all the organizational priorities, all of our governance level, and then trickled through decision-making. They help to establish strategy. We're about to enter into a long strategic planning process or strategic thinking process. And then they're automatically engaged from the get-go. And then also a part of oversight to make sure that we're accomplishing our goals and having an impact. So some very specific ways that the how we integrate advocacy throughout our organization. We talk a lot about the drumbeat, that we have to really test what we're doing. We have to be very intentional and deliberate and very concrete. And it's a lot of work, but it's in the important work. So a lot of our staffing time supports making sure that this leadership structure works well. So again, I mentioned some of our board composition. Our board of directors has very set diversity goals that include diversity almost any way you can define it. It's also very compliant with the governance expectations of the Health Resources and Services Administration for health centers. It's very compliant, not compliant. It adheres and is aligned to the National Healthcare for the Homeless Council's governing recommendations, and there's a very recent document out that outlines that nicely. And it also makes a statement about our values and our mission around equity, inclusiveness, and diversity. And we just know we're better because of it. We live that. We also incorporate monthly training that often, probably about 25 to 30% of the time at our monthly meetings. The governance training is related to policy issues and advocacy, and it could be a real to-do hands-on technique and tools, or it could be discussing emerging issues. We've had National Healthcare for the Homeless Council policy staff Skype into our board meeting so that we could have a little more dialogue and exchange. And those governance trainings hit a lot of things, but we dedicate time on our board agenda every single board meeting as a standing item. Sometimes we bring other people in. Sometimes we use our own talent. We've had some of the consumer members of the board pull together panels from among their peers and others in the community to talk about the experience of homelessness, and then we'll talk about how that ties to the priorities in our advocacy agenda, for example. We don't track the consumer members of our board of directors, so they're tracking, in quotes, for lack of a better term, but really that, because you've experienced homelessness and or used our services or similar services, you're an elected member of the board. One of your obligations is to serve on a committee, that you need to serve on the consumer committee, which people do willingly and with interest and with leadership, but they also participate on every single other of our 7 standing committees. So fund development, finance, governance and leadership training, executive committee. We have a commitment to have at least one consumer or special population representative on our executive committee and our officer group at any given time. So we set our goals high, and since 2008, our board of directors has been very, very committed to figuring out how to do this and do this well. And one decision that they made was not to opt for a consumer advisory board model of a very autonomous and respected entity that can make recommendations, possibly with some representation on the elected board membership. They decided, despite having a waiver as a special population, grantee, to go directly to the heart of governance and shoot for 50% of the board members having the experience of homelessness. We are pretty consistently since that time at least 25% minimum, and we have been as high as 49%. So we haven't quite hit the 51%, but we're working hard and we're learning every single day. Something that we also do is through patient experience surveys that are done with our primary care association twice a year, or through the Client Board Advisory Committee of the board. It's a little bit of a misnomer. It's not really an advisory committee, which is chaired by elected members who also have experienced homelessness. They conduct surveys themselves. They're doing one this week, actually, on campus to talk to people about their experience here and whether we're doing a good job at creating a trauma-informed environment. Not that the questions aren't that jargony, but we had a lot of people who do surveying help them develop that, and they're collecting surveys this week as we speak. And then we also do, in the monthly committee meetings, which will have some standing members and then also just pull people from the courtyard or from the meal site up the street. We have what we call, they're not formal focus groups, but a focus discussion session. So there'll be one focus question, and it might be about new proposed transit development in Albuquerque and how that will affect transportation. It might be about, we talked a lot when Medicaid expansion was pending about what people anticipated about that. Now we talk about their experience of it. We have talked about input to design of our new building. And so we have this standing group where we can get a lot of just sort of anecdotal or qualitative discussion going. All of those minutes are reported directly by the chairs of those committees to their peers on the board of directors, and then advocacy and policy issues emerge from there, and they analyze those. Those also go to management on a monthly basis. We do very extensive board evaluation and impact reporting about how well each committee works. And so there's a lot of reflection as well on the effectiveness of engagement. It's one of the primary measures on consumer leadership. This is how we make sure that we're not being token and that what we do is really meaningful and substantive and inclusive. So we're always watching ourselves and monitoring and making sure that we're really walking our talk when we say everything that I'm telling you today. We also have a very highly involved engagement process for selecting new members that is applied to all prospective members of the board, not just those who have experienced homelessness, and then expectations, a peer mentoring system, so that often, and so we have members who've been on the streets who are elected board members and officers of the board who are considered special population consumer members who will be a peer mentor to a new person coming in, whether they've ever experienced homelessness. And then again, I think we've described a little bit, we have a very, very strong committee structure where people engage throughout. So one last slide is a little more specific to how that all then translates into active advocacy and policy work. We have a board-approved and monitored advocacy agenda that we review with staff and consumers and partners and volunteers and other advocates in the board of directors every year to make sure that we're on track and that we're matching all of those feeder processes within our structure, that we're well aligned strategically, and that we're working and dedicating resources to the areas that we've set our priority. And some of the pillars of that agenda are always, of course, housing, income, access to health care, and then we add civil and human rights underlying. And of course, services and resources, but just getting more services and resources is not our primary intent. It's really about ending homelessness. So if you look at, what we understand as the structural model of why people experience homelessness, why some are more vulnerable to falling through, down, under the holes of the safety net, then housing, income, and access to health care are really primary. So we use that advocacy agenda. We visit it in the board meetings. We visited it in committee meetings throughout, because everything that we do is successful based on how much we're communicating with others about the community and not simply about our organization or any individuals. Oftentimes, our board policy committee and client board advisory committee, two standing committees of the board, will coordinate together very closely. Often there's a conversation about if it emerges from one committee or somewhere, which committee it'll be assigned to, and so they'll end up working together. And a really exciting example of that, and I'll end soon after this, but a really exciting example of that is our annual Know Your Rights Forum, which came from discussions and some of the focus discussions in the Client Board Advisory Committee 4 years ago about people feeling harassed on the streets by law enforcement and their experiences of that. And this was prior to a Department of Justice investigation and consent decree that has really framed many discussions here in New Mexico and in Albuquerque of late that are tied to our behavioral health system, to people that are on the streets, people most likely to be exposed to interactions with law enforcement that escalate, and then this is a whole other webinar, and then excessive use of force, and so working on what those interactions look like. So the first step they felt was that people should know what their rights are. And so 3 years ago, we always do this on or around December 10th, which is the International Global Human Rights Day, we invite in some of our legal advocacy partners to really go through understanding rights. And then we open up our monthly meeting to a community-wide forum. And we have people come, we provide food, they come with their packs and their rolls and their bags and what's on their mind about their experience out in the streets. We had probably 50 participants this last December. We also had the ACLU presenting. They often do this for us, sometimes the New Mexico Center on Law and Poverty. This time we also had a representative from the Police Oversight Board taking complaints. We had the League of Women Voters registering people to vote. It was a big community event, and we had probably 20 other advocates in the room, several who were representatives of the managed care organizations that are responsible for our Medicaid expansion here in New Mexico. So it's a great resource. It was a very exciting, and is completely consumer-led. I just provide staff support, and our partners come in, and they work together with advocacy organizations in the community. So I think I mentioned voter registration mobilization. We were really fortunate to work with NAC in the past years on making sure that we had registration available here on site. We're looking to do that again, and we also then put people in cars and drive them to the polls. So I think that's what I have. I'm going to pass it off to Jeff now, and then if there are questions later, I look forward to responding.
Hello, can you hear me?
Yes, we can hear you, Jeff.
Great. We've had a little technical difficulty here, so I'm really glad to be on. I think someone else is going to have to advance my slides. So if we can go to the first slide.
Do you see your first slide there, Jeff?
Well, I don't. So I'm just going to talk through this, and this presentation is about a specific project that we run, which is our Certified Client Advocate Program, which is the Care for the Homeless Speakers Bureau. The basis for our program has always been policy and advocacy. Not every Speakers Bureau is based on that, I know, but our operation is committed to public education and client empowerment. So this was started because our research showed that the single greatest impact on a person's opinion about homelessness policy is guided by whether or not they've had contact with or know someone who has been homeless. So this is the single best public education and advocacy method that we have. Clients, the next slide, clients are natural advocates because they can tell their real life experience, can speak to how policies have actually affected their lives, and the stories and narratives that they tell are far more powerful than the talks that professional advocates can give. In trying to put our program together, we sort of surveyed what other people are doing across the country, and that's what led us to create the training to lead to a certificate so that the people who graduate from our program are certified Care for the Homeless advocates. Our program consisted of 10 classes, a little over 20 hours. Half of the classes were devoted to public policy and half to public speaking, practice, and training. At the end of the program, at the conclusion of the classes, there was a graduation program. Each one of the advocates was presented with a certified advocate certificate that was framed, shirts, really nice collared polo shirts that that said Certified Care for the Homeless Advocate on it, and they became official members of the Care for the Homeless Speakers Bureau. So here's some of the things that we relied on in the program. First of all, it was really built around telling the powerful stories, personal stories, of how people became homeless, in many cases how they've overcome that, hooking their personal story in every case to some policy goal or agenda item, and then advocating about that policy. And we always do it in a positive way, with one of the underlying themes being that we can end homelessness. We're always truthful, stick to our care for the homeless goals, and never blame the victim. Part of the training was messaging how to talk about homelessness, so that all speakers' presentations are reinforce a shared value. We lead with shared values and human rights. For example, that housing is a basic human right, healthcare is a basic human right, that they are the moral and right thing to do, and that we can end homelessness. The final underlying point is that we always try to make is that it's not more expensive to end homelessness than what we're doing right now to not end homelessness. So half of the course was devoted to policy knowledge that is the foundation for the certified advocates to talk about homelessness. Anybody who runs a program like this would want to rewrite their own policy course that would key in on the issues and the circumstances in their community. Ours, of course, dealt with New York City, which is pretty unique, but we covered homelessness history, modern-day homelessness, homelessness issues in the United States, and the specific policies and issues that exist in New York City where we have a right to shelter. In our first certified advocate training, one of the policy issues and activities that we keyed in on was the 2013 New York City mayoral election that was going on at that time. And we actually had speakers that, one of the things we did was to try to connect a number of our graduates with meetings with candidates. More recently, we've discussed other issues, including one of the big issues in New York City, which is the rental subsidy programs and other outreach and other programs that are just being developed in New York City. The other half of the course focused on speaker training and practice, and really our clients tell us that that was very important in giving them confidence. Like any good public speaker, it's based on practice, practice, and more practice, so that the classes featured many opportunities to do public speaking. We often video recorded the speakers so that we could play it back and have peer review and critiques. Then people would do their speeches over again. And we focused on the Care for the Homeless speech model, which I had described as telling a powerful personal story, hooking it to a particular policy issue, and then advocating about that issue. Every certified advocate by the end of the training program wound up with their own completed speech using their story and an issue that they had chosen. So that at the end of the training, in the graduation, each graduate gave their own 5 to 7 minute speech, telling their own story, linking it to a position, and advocating. We did this in a pretty formal graduation ceremony that was in front of an audience of about 50, including our own board members, peers, other advocates, and a public audience. And our clients gave us a lot of feedback about the program. They told us that one of the important things that happened in the program was that in the policy end, that they learned, as one of our clients said, that some of what we knew was wrong. And that's probably true of most people, including lots of experts on homelessness policy, that some of the things that people assume or those things that we think we know for sure are just wrong. But the discussions that we had in the training program helped to debunk myths, and it gave the clients real confidence in their ability to talk about homelessness. The conversations in the course helped to reinforce the lesson in the training program. Equally important was the diverse speaking experiences in the program. That included short improvising speeches and lots of practice. Learn techniques. We gave our clients a number of techniques. For example, how to pivot. And pivoting merely means that when somebody asks about or talks about something that is not part of your topic, that you pivot to the topic you want to talk about. From the candidates for president or other political all the time. So that our clients, if they were asked a very specific question about a particular statistic or fact that they might not know, they might answer, I don't know about that, but here's what I do know. And then they would go back into their own talking points. As I said, we recorded speeches and gave lots of feedback, and we encouraged at-home practice. Even after we continue to encourage them to work with us on their speeches, to get better and better. As I began by saying, our program's prime purpose was public education. And so when we graduated our first class and began our Speakers Bureau, we really focused on opportunities to present in the community, and we focused on college and high school and grade school classes, on advocacy programs, I should add neighborhood organizations. And we also used internal opportunities so that we have used our clients in lots of our own internal programs. It is hard to start a Speakers Bureau from a standing start. And that's, of course, what we and everybody who starts the Speakers Bureau has. When lots of people have you speak, will have you speak again the next year. So that, for example, there are colleges, including graduate programs, where we generally speak every year now. We go back to the same classes, the same church groups, and the same neighborhood organizations over and over again. But there are really few opportunities in the beginning, and you have to go out and create them. The easiest way to do that is internally, so we gave lots of presentations for our own at our board meetings and at advocacy, lots of advocacy events that we hold ourselves, like Homeless Persons Memorial Day and other events throughout the year. But soon, the programs were our best calling card, so the word of mouth and publicizing the programs that we were involved in led to more and more presentations. I'm glad to tell you that in just the last 3 years, we've had more than 39 outside presentations and 6 presentations scheduled coming up. We're continuing to speak to all kinds of groups and continuing to do this for advocacy. And I would be glad to respond to any questions about this. I really encourage people to think about this as a model, although, of course, each program will want to form their own training and or Speakers Bureau in their own way. Thank you.
Thanks so much, Jeff. This is Alex Harris again, and guys, please remember, if you do have a question, type it in the chat box, or just let me know that you want to be unmuted, and I should be able to unmute you individually, barring any technical difficulties, and have you ask your question live. So in the meantime, since I'm not seeing anything in the chat box yet, so please don't be shy, I have a question for our presenters. First of all, thank you so much, Jimmy and Jeff. Those were great presentations, and it's really awesome to see all the things that you both are involved in, but also the way that you really structure the advocacy work that you do, and of course how passionate you are about the work you do. It's always inspiring. But I did want to ask, and working in the grassroots advocacy department at NAC, we have a lot of really engaged health centers that are, really excited to be doing advocacy and doing a lot of different things. And then we have some centers, particularly, centers with more limited resources that, are a little bit more hesitant to get involved in advocacy, and they maybe see, asking, their consumers or their patients or other people in the community to get involved as asking them for help and creating, a burden for them. So I would just ask, what advice you have for centers that, haven't really gotten started yet and they're hesitant for those reasons, and how do you think that advocacy can really be transformative?
One of the things I would say about our program, Care for the Homeless, is that as we have a culture of advocacy throughout the staff and the program, I think that has been a very welcome and motivational thing for our staff. I know staff members will tell me from time to time that they really appreciate understanding some things that are going on, so that when people approach them and ask them questions about homelessness, which happens very often, that they feel comfortable talking about it. So I think it's actually been a great internal motivation. I think the staff really likes it. It is, we think, an obligation of our board members, and there are really important things that we're advocating for. So, but it is sometimes a struggle to get going. You can feel really confident that once you get going, and your staff members, even though they are overworked and called upon to do lots of things, will actually appreciate the opportunity to be involved.
I would add to that. I think one thing that's very important and that is part of our culture is to really create time. It takes longer, but to create time to process, prioritize, discuss, and talk about things. So there's a lot of a sort of action and reflection cycle built into how we work together. And I think if we think about how integrated services are and the time it's taking for health centers to really integrate, we've been doing that for a long time. And I think in the same way, integrating an advocacy culture and action, consumer leadership action, and reflection about how to do that and what's important, it just takes a lot of time. And so setting time aside for it very intentionally and allocating resources and making a commitment, I think, gives people the opportunity to engage. Otherwise, just saying go forth and advocate is a bit of a free-for-all that doesn't necessarily get to the impact, and also doesn't make people feel like they're effective and confident, to what Jeff was saying in terms of preparation. So our advocacy agenda really becomes a beacon. Everybody informs that, and then they go forward with that. I also think that we work on things that, when I talk about emerging issues and all the different ways we identify what's important, we learn so much from the National Healthcare for the Homeless Council and from the National Association of Community Health Centers. We watch what our national partners are doing because there are people who are able to do some of the analysis and strategizing that maybe we don't have the time to do, but we can link that to very daily experiences of things that people care deeply about. And so when someone is outraged or upset or fired up, we take advantage of that and we get some buzz going around it. And then, the more generic advocacy action or advocacy, we also invite a lot of people, when people have something on their mind, we invite a lot of people into our campus. So our Congresswoman is here frequently with her staff. Her staff, they do mobile office hours here because they realize that this is a place where we have space, where the community comes and when we talk about issues. So that really works for them. But we also have our consumer leaders sit down and talk with them. There's a very, I think, funny story. The last time she was here, her name is, the Congresswoman is Michelle Lujan Grisham, and she's from northern New Mexico. And anyone that knows her has seen her. She's very gregarious, loves to be out in the field with her staff. And one of our board members who also has been homeless is now housed and used our Services and is ending his first 3-year term, has met with her here on campus before. And the last time she was here, we were meeting about something different with a different group, but he happened to be here in our Art Street community doing some art that day. And I think they call, his name is Jimmy Lujan. So they're Lujans from northern New Mexico, and I think they call each other cuz now. But we've just really built that into you know, how we do what we do here in our vital communication every day. And we go with the issues that people care about, and then we demystify the process. Half the time when we take people to our state legislature, it's as much to go around and visit with elected officials as it is to just sit and watch the process from the gallery and see how the House floor, the Senate floor works. And to really, if people come back having demystified that, realizing that this is their right and this is what they should be doing, and then having that experience, I think then you can't stop people. I have not led one group to our state legislature in probably 5 or 6 years because there are staff members and consumer leaders and elected board members who want to take a small group around and visit with their list of legislators on our issues. So that's pretty exciting. It takes time, though. It takes time and an investment of resources.
Thank you both for those answers. I think that was great. I would want to build on that also, focusing especially on why the importance of building time for building advocacy into your organization for consumers is especially important, and a lot of what Jeff raised is when we talk to consumers about the broader understanding of policy issues and how they affect lives and create situations that people are going through. It really helps people understand their individual experiences within a broader context, which can help fight a lot of the stigmatization or the internalized oppression that a lot of our traditionally marginalized clients can feel. So I think engaging in advocacy has a lot of clinical benefits that are important for our consumers. We did have a next question that I wanted to pass on here from, then this one's to Jenny. You mentioned about a 3-step vetting process for your board members. We were wondering if you could expand on that a little bit more.
Sure. We have, for anyone coming in, did you catch the first part of that? Could you hear me?
Yes, we can hear you.
Okay, great. So for anybody who's being considered for our board of directors, it's a long conversation, as long as anybody would like for it to be. And so we have, for example, someone probably being nominated to our board next month who just recently got housed, who has been engaged through our Art Street community as well as through our Client Board Advisory Committee as she was able when she was on the streets. And that conversation has been going on probably for a year until she felt like she could come on. We also have another board member who is the Director of Risk Management for a major healthcare system here, and she's also having a very long conversation with us. And the steps that engagement is about an initial conversation with someone representing the organization. And often it's peer-to-peer, reaching out over coffee or a phone call and just saying, hey, have you ever considered, and could we bring your name forward to go into the process? And then there are a series of orientation familiarity activities like a tour down here on site. Some people request more documents, more information, and I can send that to them. Some want to meet with specific staff or particular board members to just have a very mutual conversation. So there's a conversation that is informing about the organization, about our board. And then there's a formal piece toward the end that is a formal interview with the governance committee leadership that is documented in the minutes, and then a meeting with the board of directors, at which point someone often comes through as a nominee and then is elected. And so it's really, that can go as quickly or as slowly as someone needs, so that by the time we've had this long mutual conversation, everyone has a pretty good idea of what they're getting into. And I think that as well then as the orientation process, has really helped with retention.
Great, thank you so much. And just to our panelists, we've got another question, and you know, feel free to answer this however you feel is best to answer it. But I wanted to know a little bit more. We got a question from one of our attendees about how you guys encounter some challenges to engaging consumers, what those challenges are, and then how you work to address those challenges.
I would say that it's not unusual to have challenges internally, even when you first start up some of the programs. I spoke today about our Speakers Bureau and our training program. At the very beginning, before we launched that, there was a little pushback within our organization about whether we were opening ourselves up to a reputational risk, whether somebody would say something that was wrong somewhere sometime. And of course, the answer to that question is absolutely, somebody will say something wrong somewhere sometime. And that would be true if we only had staff out speaking, or if we only had, if I was the one out speaking, or if it was the members of our board. You know, if you do it often enough and get, somebody could say something that would be wrong, even embarrassing. But I think it's really important to have those discussions internally so that people grapple with the question and understand that you know, that we are going out to do the best we can, and that this is really a valuable tool for us in our advocacy. But I do think that there are challenges and pushback, and that you should state that when you're first developing some of these programs. I think that the success of the programs are something to build on. I don't think we get much pushback at all today because of the value of the client engagement.
I don't know if Catherine or Matt have anything to add, but I would say, I mean, they're the real obvious things like material sorts of barriers, transportation, gas, food, and I think what we have learned is that's really important for all board members. Anything we do to support a board member or a leader or someone engaging in our policy or strategy work in the community, that sort of those assumptions about who needs those sorts of supports and material supports, I think we've found could be anyone. And so we make it available to those sorts of real basic things, concrete things. But I think mostly one of the biggest challenges is sort of not knowing how to talk to one another across experiences. So doing, I think Jeff mentioned this, doing our own internal work about understanding one another and not making assumptions, and to really build mutual relationships and not sort of the people who've never been homeless and the people who've experienced it, but to really just build those people relationships and really learn how to learn from one another, which gets over assumptions about what people can or can't do and what really are challenges that shouldn't be challenges. I think some of those we create ourselves in our minds and experiences and attitudes, not because it's good or bad, but just because that's who we are and what we bring without doing that deeper work to have those conversations.
Yeah, and I would agree, and I would maybe just build on that with what Jenny's talking about when engaging consumers and staff. I think there's different power dynamics and experience dynamics about trying to truly empathize with one another that's important to understand and engage. And other challenges when you're talking about groups of consumers, I think can be very similar to any group that we have been a part of. Any new sort of group that is forming with people in it will have different dynamics and will have challenges that they have to occur because humans can be difficult. And so I think that we all just have to acknowledge that consumer groups have maybe different challenges than other groups that we're involved in terms of people being able to come to meetings or access their basic needs, or experiencing trauma, reliving their trauma, or understanding other people's trauma. So I think some of the challenges are different than other groups that people are in, but I think there are absolutely ways to overcome those in being very open about discussions about trauma and what is trauma and how to relate to one another, and a lot of kind of the social work, active listening kind of skills, and just being very open about some of those experiences with one another and about the dynamics within the group.
Great, and this is Alex again, and I'm not seeing any other questions in the chat box, but if I'm wrong about that, please feel free to type something in. We have 3 more minutes. But to be mindful of everyone's time, I mean, you guys will see up on the screen now a list of our contact information, Matt, Catherine, and myself, and then of course our 2 panelists from Healthcare for the Homeless site, Ginny and Jeff, who did a fantastic job. So thank you all for being on the webinar, and just to let you know, we are recording this webinar, and we do have these slides available. So once the recording is available, probably early next week, we'll be sending that to you guys who are on the webinar today. So feel free to share it with your friends, family, colleagues, you know, anybody else that you think might be interested who just wasn't able to join us live today. And with that, I'll just open it up to any of our panelists for any final thoughts or final words.
Well, I just want to say thanks for the opportunity. It's been, this is a great issue, great subject to talk about. We're really pleased to be involved.
Thanks so much. We appreciate your involvement, and please stay tuned because we do have a Part 2 webinar coming up on Wednesday, April the 6th. It is the same topic, but we will have 2 additional speakers from health centers that will be sharing some of their advocacy programming with you. And that's Gary Cobb from Central City Concern and Adam Schneider of Healthcare for the Homeless. So, and I will be talking a little bit more about some of our advocacy resources and programming at NAC. So please join us again on Wednesday, April 6th. And otherwise, I hope everyone has a great rest of your day.